Good afternoon and welcome to the CEO Roundtable on the challenges to rural healthcare. I'm Bill Hoagland, Senior Vice President of the Bipartisan Policy Center in Washington, D.C. And though I work in Washington, D.C., my heart and my family farm is back in Indiana, so I have a good sense as to the challenges that face rural America. With me here today at the Dartmouth Health Studios in Lebanon, New Hampshire, are the three leading CEOs from the northern New England's most rural academic health center systems. Dr. Joanne Conroy is the President and CEO of Dartmouth Health and soon to become President of the American Hospital Association. Dr. Sunny Eappen is the CEO of the University of Vermont Medical Center Health Network, and Dr. Andy Mueller is the CEO of MaineHealth. I'm sorry, Andy. It is okay for each of you. I'm going to refer to you in the first name as opposed to your formal titles. To our viewers, thank you for joining us today. We are going to spend the next hour talking about a critically important topic that is on everybody's mind, I think, particularly in this area of the country, and that is the issues associated with rural healthcare delivery. Some people are saying that our rural healthcare systems are in a crisis. I believe, Joanne, you had indicated in an op-ed recently that if you thought the pandemic was bad, just wait and see what's coming still. This is an issue that I think that a lot of us are focusing on and exploring the question of how to deal with healthcare solvency, delivery, sustainability in rural northern New England. Whether you're a patient, a family member, a community member, or a lawmaker, please stay with us through the hour. You'll have a chance to learn from these experts and about the future as they see it, and you can ask your own questions of the three leading CEOs about what they see as the cracks in the foundations of our healthcare system and what we can do about taking these on before it's too late. The program will be broken down into three 20-minute segments. First, what it means to be a rural academic health center. Second, we're going to focus on the challenges that healthcare is facing in our region, in this region. And third, the innovative solutions to address those challenges going forward. Those of you who are watching the live stream will be able to ask questions during the last 5 minutes of each segment. To ask the question, simply type your question into the chat feature of the live stream and we will see if we can get to it. We may not be able to get to all of your questions, but we will try as best we can within the time that's available to us. So there is a lot to discuss in the next 60 minutes, so let's get right to it. Let me begin with that first question as it relates to the academic health systems. What does that mean? And I'll begin with you, Joanne. What does it mean to be an academic health system?
Thank you. We do a lot more than just deliver clinical care. We also educate, do research, and actually contribute to the conversations about public policy in our region. So to be an academic health system means that it's more than just the academic medical center. At Dartmouth Health, we have a network of small critical access hospitals across New Hampshire and Vermont, community hospitals, as well as visiting nurse and hospice organizations. So when we aspire to be an academic health system, what we want is to educate not only in the academic medical center, but push the educational opportunities out into the community. We're starting a new family practice residency in one of our smaller PPS hospitals in the southern part of New Hampshire. We have developed workforce readiness programs to educate people as they graduate from college or from high school so they can join our team in terms of academic health careers. And then a research infrastructure. We want patients to be able to access the research that will actually change their care as close as they can to their home. So we want people to be able to access clinical trials when they have either a difficult to treat medical condition or a cancer. we would like them to be able to access those trials close to home. And considering that all of our health systems are separated by hours rather than miles, it requires us to think about how can we actually do this better as a health system.
Sunny, what are the similarities of your academic health center?
I think it's largely the same. We have the same both approaches and challenges, I guess, in the way that we look at that from an academic medical center system. We've got a spoke where we've got a 560-bed hospital that is the academic engine, medical students, residents, all sorts of trainees coming through there. We want to push our research out. We want to push our education out. It's probably worthwhile to just take a moment and think about just us in rural healthcare and think about what that means for us. I don't think most people realize probably about 50 million Americans, 45 to 50 million Americans live in what would be considered rural America from the CDC. If you look at the top 5 reasons that people die in America, heart disease, stroke, pulmonary disease like COPD, unintentional car accidents, shootings, or cancer, all 5 of those are all higher in the rural parts of America for a variety of reasons. And so not only do we have to kind of provide care at that very high level, but we've got to provide it in a very broad geographical area as well. So I think from an academic point of view of how do we educate, how do we do research in that broader area, as well as how do we deliver care in that large geographic area for sicker patients that are having higher mortality. All of those are our challenges.
And Andy, MaineHealth, how does it fit into being an academic center?
Yeah, I think with a footprint and resources similar to the other 2 systems in the region, we do a couple of things that I think are really important. To Joanne's earlier point, one of the things about being a rural academic healthcare system is the ability to train medical students, residents, nurses in a rural setting. And many times that encourages them to stay and continue to practice in that rural setting. So we have a huge obligation to continue to train the next generation of caregivers, not just at the academic center, but also in the rural communities. We serve those 50 million people that Sunny referred to really deserve good care. And so we're constantly thinking about how we can ensure that there is a pipeline of all the clinical specialties and disciplines required to deliver good care in rural communities. The other thing that all of our systems do too, which is really important, is we also partner with other academic institutions in our communities, other colleges, universities, technical and community colleges, to help serve as a training site for many of their learners, participate in biomedical engineering research, for example, or other research that may be partially clinical or non-clinical but still has a healthcare application. And so the ability for those other institutions to partner with us gives those other rural institutions of higher learning a real opportunity that they may not otherwise be afforded.
Joanne, I don't want to put you on the spot, but one of your op-eds recently said that we have trained doctors like we've trained them for the last 100 years. And some indication in your op-ed that maybe there's a different way of training.
We have an apprenticeship model, which we've used for years, and yet we haven't really focused on competency-based advancement. How do you move people through the training process more quickly? How do we use simulation and how do we use technology to give an experience that doesn't necessarily have to happen at the patient's bedside, but actually gives people an opportunity to take some risks and hone their skills in a safe, simulated environment. We know, for example, that orthopedic surgeons in Canada, they did a study in one of the cities in Ottawa where they took a physician in training and they put them in a simulation lab for 4 months before they touched a patient. And when they actually completed their training, they were actually quite good at a lot of the skills that are important for an orthopedic surgeon. And then they could spend their training learning about surgical and medical judgment and interacting with the patients and their families. So it was those other aspects of care that have to be done at the bedside, but their training actually was accelerated. There was an interesting conversation with somebody I had who was on the ACGME board, and he said, how can we train a 25-year-old to take off and land a fighter jet on a Navy ship
Aircraft carrier.
in such a short period of time, and we can't train our medical professionals faster. It's a good point. I don't think we have the answer, but we should sure look at it.
I'm curious about what you mentioned in terms of having trained doctors to remain in the same vicinity. Sometimes my experience has been it also depends upon the spouse of that doctor or person. How do you encourage people to stay after they've been trained in your systems to remain here in New England and not go someplace else?
Yeah, for sure. So we've known for years that where people train, that they have a greater likelihood of remaining in the community and continuing to practice. And so we've applied that knowledge and theory to really start expanding our undergraduate and graduate medical education programs to our rural facilities. So, for example, we have a smaller community in Norway, Maine, where we've now had an internal medicine training program. And of the 4 graduates of that program, 3 are actually remaining in Norway to continue practicing primary care, which is hugely important to that community. And so by giving them the opportunity to experience life in a rural community, to understand what it means to be a physician in a rural community, we're really giving them the opportunity to really fall in love with that type of practice and continue to remain there after they practice. Now, Bill, your point about finding opportunities for the spouse is real, or a partner. There's a reality that in rural communities we may not have as many opportunities as real large metropolitan areas. And so that's something that we have to really be thoughtful about and try to think about how we can partner creatively. And fortunately, in the post-pandemic environment, people have the ability to work more remotely, which we think gives us some really great opportunities to give people the chance to raise their family, to live a great life in a rural community and still have the richness of a rural practice.
But I think your point, Andy, that you made earlier around partnering with all the other colleges, so it's not just the medical college, it's the School of Nursing. We need respiratory techs. We need folks that are working in food service, right? We need everything, quite frankly. And so I think hitting those pipelines early, with all of our opportunities, and then looking for both and thinking about that both early, both partners in that relationship, is really critical for us to be able to hang on to those folks.
Sunny, that comment about the pipeline makes me think, let's go even deeper. To what extent are you in the high schools, in the community, in bringing those students' interest into science and into medicine?
Yeah. Every one of our communities has a high school outreach program. So when they're coming in, whether they're working with the pharmacists or the respiratory therapist, the idea is how do we get them interested in thinking about the hospital and all of the things that we need in a hospital, because it ties folks to the mission of what we're trying to do, right? We're trying to keep people healthy. Whether you're an accountant, we're trying to keep people healthy. That's your job. The work that you're doing is behind that. And so we have to kind of instill that in our working group, and we start that really early as we can. The other pieces, I think that we're all doing is, how do we fund it?
Yeah.
How do we get people attached and then say, can we help you with your loan repayment plan? How can we help you with your housing so you'll stay here? Because I think people, once they've tasted it, they really like the life that's out here. Now it's up to us to create all the opportunities to make that as easy as possible and attract them to stay.
And before we move on to the second segment of our conversation here, let's talk about the cost of educating in medical school and the burden that's laid on them as they leave in terms of loans. What's an average? Can you give me a sense as to what it costs?
I've spent 6 years at the AAMC, so the average is about $110,000. Although the extremes are...
That's just for the medical school.
For the medical school. That's the average debt they leave medical school with. But the extremes are significant. From some people will have a $250,000, $300,000 worth of debt, especially if you include some of their undergraduate debt. And there are some students that have very little debt. And that's either because their families are actually able and willing to support their educational path. Maybe they have a scholarship, because many of our programs are actually funding scholarships to actually change that burden. there's a great concern nationally that as the cost of going to medical school goes up, it becomes unavailable for people who come from under disadvantaged backgrounds.
Sure.
And that's not what we want to do. That's absolutely the antithesis of what we want to do.
I said we were receiving a question here. I'm waiting to see what the question is. So 110,000. That's not counting the undergraduate if you take a loan there. How long would it take a doctor once certified, once out there, to actually recoup that? Let's say, is that a question I shouldn't be asking, or is it?
It depends the specialty that they
Sure.
decide to go into. Also, it depends on the type of loans they have. If they are federally subsidized loans, which have a lower interest rate, that becomes a little bit more manageable, but many of these students have to get into what we call the plus loans, which actually the interest rate is quite high. And it takes a much longer to defray that loan. And you cannot eliminate student loans by any bankruptcy proceeding. They are your loan until you pay it off.
We're going to move on to the second area of challenges. Now we're really going to get into it. Andy, what do you see as the most difficult challenges that your system is facing? And obviously, let's talk about workforce and wages and housing, transport. What are the big issues that keep you up at night, I guess?
Yeah, workforce and wages and transportation and housing for sure. The workforce challenges right now are immense. We've had, a significant wave of individuals retire from healthcare professions over the years. And this has really impacted not only physicians, but especially nurses and many of our other critical professionals in our facilities. In addition to that, we've got a lot of interest in younger individuals who want to learn, but there's a delay from the time that they begin their school to the time that they enter their workforce. And this has created a huge workforce shortage that all of our health systems are trying to work through at the moment. This has forced us to really make difficult economic decisions around the future of our healthcare systems. And despite the really big buildings and the expensive equipment that we all use, the reality is that virtually 2/3 of our costs as healthcare systems are our frontline workers. It's their salaries and wages. And so we've tried to remain competitive. And even though the three of us in northern New England are in rural communities, we're still close enough to big metropolitan areas as Boston and areas of Connecticut and closer to New York City that we're still forced to compete with some of the city rates for things like housing and other costs of living items that put additional pressure on us as rural healthcare systems. Housing, I think, has become a universal challenge everywhere, and I think all of us can talk about the stories of nurses and physicians who've ultimately rescinded job offers that they had originally accepted simply for lack of finding a suitable place to be able to afford to live. And so that's something that I think we're all trying to figure out ways that we can creatively solve. And then one of the other unique challenges to northern New England is, even though the geography of our states is relatively small compared to many others, the vastness of the states internally, because of the rural nature, means that it really is traveling by hours as opposed to miles, which puts a lot of stress on us in terms of thinking about how we meet the needs of our care team as well as the needs of our patients across that geography.
Joanne, from your perspective, what are the most difficult challenges that your system's facing? And let's talk about your financial issues experiencing in the post-pandemic. You received assistance during the pandemic. That has now been withdrawn.
Yeah.
Tell us about your challenges.
So 70% of the hospitals last year were in the red in 2022. So we're not alone, although in rural America, the challenges are a little bit more difficult to navigate. And especially in New England, which has not bounced back like other areas of the country post-COVID. And make no mistake, the provider relief funds, they were huge to allow our hospitals and our rural hospitals to recover. However, post-recovery, these are the challenges that we're facing, and we're facing them all at once. Workforce shortage, which affects all of our institution. And then if you can find the workforce, the costs are escalating, either because you're paying premium labor, and that means people to work overtime, where you pay extra for them to do that, and or contract labor, which are what we call traveling nurses and technicians that come and often make 3 times what the average technician or nurse would make.
Yeah, now that the pandemic is over, do you still have the traveling nurses issue?
Because our workforce shortage has not gone away. It is still, and all of us are committed to keeping our beds open. You know, there are some hospitals that can close their beds. We can't close our beds because we're the safety net for
Right.
New Hampshire, Maine, and Vermont. And people depend on us to keep our beds open for the high acuity patient that they cannot care for in their smaller facility.
I maybe shouldn't ask this question, but I'm going to anyway. Does the fact that you have the traveling nurses and a pay scale that may be different than your current staff, does that create friction, tension within your organizations?
Absolutely. Our nurses are very smart, and they say, I am working really hard, and this person standing next to me is making 3 times what I make. Now,
Yeah.
we know that the demand for travelers is going down. The average hourly compensation that we're charged for that nurse or technician is going down. That's going to actually decrease the gap between that nurse that's our employee and the traveling nurse. But in order to retain and develop our employees, we actually have to increase their compensation. Our costs have gone up across our facilities between 12 and 15% in labor, and yet we're not in a position to actually pass that on to a consumer or an insurance company, and that is actually creating the financial gap for all of us. And on top of that, we have a lovely thing called inflation, which is increasing the cost of supplies, but actually it affects our employees. It costs them more to feed their families and to drive an hour and 15 minutes to our facility to work. So all of those pressures are kind of coming to roost at once. So I like to say healthcare is kind of a rough business right now, but it's really rough in rural America, where we don't have public transportation and we don't have adequate housing, believe it or not, to actually get people to actually come and settle and create that stickiness so they'll stay in our communities.
I mean, I think it's worth emphasizing the issue around the inability to close beds, right? It's not, if you were in any other business that was looking to be profitable, you wouldn't continue to do what we're doing, which is keep beds open, because when we shut those off, that means that someone's not getting care that they deserve or need to get. That's the big challenge.
That's your mission. Your mission is
that's our mission.
That's your mission across the board.
And so when we have, so when you talk about the conflict, yeah, there's a little bit of conflict between the traveling nurse who comes in, but it's more of the fact that, yes, they're getting paid a lot more. There's this constant need to reorient, bring them up to speed. That takes time. And they're not a part of the community like our permanent staff are. So that's the friction that exists there that we'd love to get beyond, but I think can't see it in the near term, right? Because we know that there's a shortage of nurses, of doctors, of all of these employees that are in the healthcare workforce. So that's going to be a challenge for us.
Yeah, for sure. And Bill, one other thing that I think we'd be remiss if we didn't mention that I know is keeping all of us up at night is our society has changed. And so we lack a lot of the civility that we once experienced, and we've seen some pretty horrific events occur in healthcare facilities. And so one of the things that we're spending a lot of time, energy, and effort thinking about and doing is figuring out how to really protect our workforce, and that psychologically, emotionally, and physically from individuals that aren't always nice, polite, and in other instances across the country have actually become very violent toward our workforce. And so we're having to spend a lot of time, energy, effort, and money to try to make sure that our workforce is safe.
This issue of violence and the increase, was that pre-pandemic also, or was it basically pandemic?
We started seeing some of it begin to rise before the pandemic hit, and I think the pandemic just accelerated some of the tensions that were already evolving in our communities.
We got a question from the audience, which is an interesting question. As I know, the president and the speaker are meeting as we speak here. What are the implications for health care on Congress's failure to reach a deal on the debt limit? Do you want to anybody want to comment on that?
You know, our biggest payer are our government health plans, Medicare and Medicaid through the states. And if they decide they can't pay us, we go further and further into our cash reserves, which have been under a tremendous amount of strain over the last 18 months, 2 years, and the end of the pandemic. You know, we go into our own savings account to actually keep the doors open until they are able to pay us. It is a significant impact.
Medicaid, I presume you have Medicaid patients and you serve them, serve everybody. It's a matching program between the feds and the state. If there was actually a failure to reach an agreement, would your states continue to pay the full benefit that the providers provide on the anticipation that at some point the federal government would reimburse the state? I'm trying to make the case here Medicaid might be different than Medicare.
I think Medicaid still, I mean, even though there's a state matching program, it really relies on the federal government to get those. I think the states would all do their part. I think all of our state governments would do the best they can. I think the other part, so the obvious one is, can they pay their bills to us directly, and what
Yep.
does that mean if they can't, and what would we have to shut down, because then we can't pay people. But the other part is that all of us are also invested in doing other things for our organizations. So the cost of lending goes up, and that really then would limit what we can do for our patients, right? We're doing it for our stockholders are our patients.
Mm-hmm.
And so when we can't borrow at the same rate, that means we can borrow less, that means we can do more. We do less with that, whether that's buying the state-of-the-art equipment in the operating rooms or building operating rooms because we need them. Either way, right? That hurts our patients at the end.
Sunny, go
And at
ahead.
the same time, you know, there's plenty of evidence in the medical literature that psychological trauma will ultimately increase demand for healthcare services. And so we have a populace that is going through incredibly difficult economic times as a result of failure to reach agreement. Then there's a reality that we'll see more emergency room visits for heart attacks, strokes, behavioral health issues, for sure.
And they're going to lose their jobs, and they're going to be on different, they're going to rely on the government for insurance away from their commercial insurance. All of that. It's just a cycle of.
The other question from our audience, see if I can understand. Even if they do reach a deal, personally I think they'll have to, what are the implications for hospitals on reductions being discussed? Site neutral payments, 3.4B. I believe the president made it very clear that Medicare was off the table, and I believe it is. There is discussion about a Medicaid work requirement, but what would be the implications? Let's assume they reach. Still pressure in Washington to focus on Medicare, Medicaid, hospital cost increasing.
Even though they say Medicare is off the table, maybe not explicit in that is that doesn't mean cuts to providers are off the table. So it means that they'll maintain the beneficiary services, but it means they may give us less money, and we're already being paid about 80% of the costs of delivering care to Medicare patients, and the language does not say that they won't cut support for providers who are actually delivering those services. So number one, that is one of our major concerns.
Got it. Very good.
Yeah, and Bill, you know, we have an obligation as not-for-profit healthcare systems to provide our care for the entire community.
Right.
For those who have governmental insurance, whether it's Medicare, Medicaid, those who have commercial insurance, those who have no insurance or no funding source or no ability to pay. And so this could be devastating to us for sure if we continue to see the payments that we do get at the present time continuing to decline. Our workforce has worked tirelessly through the pandemic, and they're not interested, again, they're our largest expense, they're not interested in earning less in the future in a competitive work environment. So at some point we'll have to have really difficult conversations about our ability to continue to maintain the services that we maintain. And the big secondary impact of that is not lost on any of us that we're our state's largest private employers. And we have a big economic impact in terms of the ability to create jobs, to give people good pay, and to really help stimulate the economies of the states we serve. If we're impacted to the point that we have to reduce services, not only do we run the risk of individuals being harmed by failure to access care, we also run the risk of really damaging some of our rural communities economically and socially. In many cases, we really serve as an institution of community in some of these rural communities. And so if we start to suffer, then unfortunately that has ripple effects throughout the entire fabric of our society.
I was impressed by the fact that when I added it up, I think 55,000 employees between the three of you and your three, that probably is an understatement, but 55,000 is a very impressive workforce that you have to manage here.
Although I would say more impressive is what every single one of those employees did over the last 3 years. And I feel that sometimes people's memories are too short in Washington. For us to go from having an army of heroes that put their patients above their own personal safety to kind of being a budget line item that is under scrutiny at whether or not we're delivering value. Somehow that's hard to translate to the 55,000 employees that are in our combined organizations.
We got another question here, but before I go to the question from the audience, Sunny, I want to ask you about private equity and its impact upon your systems and what that means.
It's a really good point. Private equities come in many different levels, right, around healthcare, whether that's the large companies that you hear about or even small ones. And I think in lots of ways they've been really innovative and creative in the way that they're pushing us. But I think the really important thing to remember is that at the end of the day, they're trying to make a profit. And so they find niches in the system that is profitable. They either pull those patients out that are wealthy or that they can make money on, or they pull those acute conditions out that they can make money on. And then they extract those dollars out of the health system because they're paying their stockholders. And that contrast to what we're doing when we make a margin and try to make a margin is our stockholders are our patients, are our communities. And so we put it right back into our hospitals, we put it right back into our people to reinvest in that. And so when people see that innovation and they see companies making $15, $20 billion in healthcare, what that means is they're pulling those $20 billion out of healthcare, whereas we're putting it right back in, right? So that's all of our tax dollars, as well as the commercial dollars, but it's really the tax dollars that are getting pulled out. So it's something that people ought to keep in mind and how we need to regulate that if we're going to move forward in a way.
There's a couple of questions here that have come in. Let's back on the workforce. There seems like there is a dearth of mid-career providers. Early careers get started, then leave. Older providers cut hours, retire. How do we attract and keep middle agers? That's pay, housing, school, partner employment. I think we discussed some of this, but is it in the middle of the careers that's where you're having your difficulty?
Yes, and I would say that we probably have to look at what's important to that employee at that time in their career. And early in their career, they're thinking about loan forgiveness, trying to find a house that they can afford. And at the end of their career, a lot of times they're thinking about their retirement, about how can they actually contribute to their communities. But that mid-career, they need things that we haven't settled yet as a country or as individual organizations. Childcare. They're looking for housing that they actually don't rent, but housing they could buy so they can be part of the community. They're looking at career ladders, which we've become far more facile in creating career ladders in every single aspect of our workforce. They want to know that they're going to be part of an organization throughout their entire career, an organization that they're proud of and that supports them. And that means looking at our benefit structure, that means really shaping our programs to actually support that mid-career individual. We want them to work with us at our facilities rather than leaving because they don't feel developed to go to another part of industry.
Yeah, and I think we have to be a little more creative. The 40 hours a week, maybe it needs to be 32 hours a week. Maybe the hours need to be more flexible and adaptable. I think as an industry, we've been more rigid, and I think we're going to have to be more creative, almost the Uber of how we deliver care. So if you can imagine, shifts going up and people can pick them on their phone for the next day. Oh, my husband's home today, or my wife is home today, or my spouse is home today. I can work surprisingly, and I can pick out and say, oh, look, there's an ER shift that's available. I can go for that. So I think we need to be more dynamic in the way that we think about it, along with all the things that Joanne mentioned. I think those are critical.
I think this is one of the last questions before we go to the next segment. I think this is for you, Sunny, because of knowing your previous employment. It says, in addition to trying to attract doctors, nurses, and other key workers, how are you working to improve diversity in rural health systems? And how difficult is this in a rural area? And I believe, if I looked at the statistics, basically New England is white.
Yeah, so when we look at certainly in our catchment area where we cover northern New York and Vermont, it's probably among the whitest areas in the country, 92-93% white. We've taken that doesn't mean that we don't have any diversity. We have Native Americans, Abenaki in our area. We have Africans who have settled here, Afghan, Nepalis. So there are people that are of diversity, but we've taken the stance that we need not to match our community, but exceed it, because that diversity, we want to be the role model of what value that brings and the creativity that we're going to be able to offer, both in our workplace. That inclusiveness means that you can bring your whole self into work, and that goes beyond race and ethnicity, but sexual orientation and gender identity, that you can be yourself and come to work here, and we're going to be better as a result of it. So that's the model that we are putting out. We recognize we have a lot of work to do. We still have these disparities, right? If you're poorer, if you're black, if you're brown, your health care really does matter. That is the quality of care that you're delivering. Your screening rates for mammographies and colon cancers are different. And so we've got to take those on as part of that same work of what do we need to do differently, both structurally as well as in the way that we think about how we're going to get equitable care out there.
And we can go back to the academic system itself. How do we attract minorities into the medical profession in terms of the number of African American doctors relative to the African American population is so much? It may not be just for this New England, but it's an issue nationwide.
Yeah, no, I think it goes back to being equitable, meaning that we have to reach out and make even greater efforts to be able to connect with folks that have typically been disenfranchised from coming to join us. And so how do we create an environment to make them more welcoming? Everyone that needs to get into that space. And so it means taking that extra effort and saying that it's okay to do that, right? That fundamental piece of yes, I'm going to make an extra effort. It's not going to be the same effort. I'm going to make more of an effort, and that it's okay to do that. Mm-hmm. It's not universally accepted that that's okay, right? That's the step.
For sure, and I think Sunny really hit the nail on the head on a big point around health equity. We have a real opportunity and obligation now to continue to focus on health equity and ensure that we really are treating our communities in a similar fashion. And there is diversity there. We just have to continue to look for it. And in addition to that, there's a reality that it's critical for our organizations, because we're not going to have enough of a healthcare workforce to sustain our organizations in the future unless we recruit from outside of our area. And the reality is the rest of our nation is becoming less white. And so we've got to be able to attract a more diverse workforce.
I have just two quick questions, I guess, and just general questions from my perspective. We had an earlier conversation about violence in hospitals. The viewer wants to know, is this in hospital, is this from patients? And what can hospitals do to protect workers?
So it is from patients and family members who verbally or physically abuse our employees. And we're actually pretty explicit about our environment being one of hope and healing, and that if individuals actually abuse our employees, we will take action. And what is fascinating, though, is that it's often our employees that are very understanding of the stress that the family is experiencing. And more often than not, they will say, "It is okay. I understand what they're going through." But we need to be really clear. And I think that's why there's some legislation federally about treating healthcare workers like airline employees, that if somebody attacks them, it becomes a federal offense. And it's probably a long time coming. I think it's just important to set guardrails about respect and the environment that we're in, and understanding all the tensions that both our employees and the patients and their families are feeling. But there's a level of respect and behavior that we absolutely have to adhere to in our organization.
This is more of a personal question I worked for a United States Senator from the state of New Mexico. And so I had to deal a lot with our Native Americans. You mentioned you have Native Americans here also. A low percentage relative to, say, New Mexico or Colorado or the West. Is Indian Health Service here or not? Do you have any interaction with them?
I am not aware of any Indian Health Service here. It's similar to when we were talking about county hospitals, city hospitals. We are the service that provide.
You are the service.
Yeah.
You are the service. Okay. Thank you. We're going to move on to this final section, the simple part, the solutions. Give me the solutions. And I'll lead with you, Sunny. It still says here, innovation. And I understand, Joanne, you have some thoughts about artificial intelligence and all that. Tell me what's the solutions going forward?
Well, I think there's going to be a lot of solutions, but I think it starts with us being more creative and innovative, and that means both our patients and our healthcare providers have to be thinking a little bit differently about providing care. So the idea that many of us have today is that you have a relationship with a doctor, and that's where you get all of your care back and forth. And the idea that instead that we need to wrap around some services so that the pharmacist, the social worker, the community health worker, the nurse practitioner, the physician assistant, all of them play a role in the care that you deliver. And so that when you come in, sometimes it may be the most appropriate person you see as a pharmacist, because that's what you need. And so we have to think differently about just using the people in a way that we're raising everyone up and allowing the doctors and the nurses to really work at their highest level. That is easier said than done. Everyone has to accept that.
It's a system. It's a system.
It is. It really is. And then the technology piece, all the technology that actually exists today, we've been very slow to adapt. Everything from scheduling on your own. Can you schedule your own appointment, or you get a radiology exam that gets ordered? Can I look at the schedule that's out there and choose the place that I want to go when I want to go? This is already out there. We can make restaurant reservations and airline industry reservations easily. We need to do that. Virtual care, the idea that you can actually get your care on your phone, and that we ought to just make that easier to do. It also comes from the other side, which is the enablers around that, right? The payers, the government, the commercial insurance. Can we pay for that in a way that makes sense for our providers and our healthcare systems to encourage that kind of behavior? And when it is appropriate that you see a pharmacist or a community health worker, that you still get reimbursed for that. That is the right care at the right time. Don't discourage that by saying you have to see this provider to get paid. So I think all of those things, and then there's so much more.
You haven't mentioned telemedicine. Is that a future for us, or?
The future's here.
Yep.
I think COVID pushed us, because the technology was always there. It just pushed us to allow to do it, and then the idea that the government started paying for it for those visits at the same level as an in-person visit just blew it up. So we went from essentially 0 or 0.1% to up to 40%. I think we've sort of settled in the 20-25% range. I think there are some things that I think people have adopted and adapted to. Behavioral health, doing telemedicine, virtual visits, you could virtually do it all the time. Compliance is better. People actually show up more often. They don't have to worry about buses or trains or getting there on time or worrying about their kids. You can do it from home and you show up for that. There may be other things that just don't work as well for that. So we have to find the right balance on that, but I think the reimbursement piece winds up being really important to continue that. But I'm thinking about even other things. Imagine going into an emergency room and as soon as you get there, your phone checks you in and then you start putting your symptoms in. That automatically comes into your electronic medical record. So when the nurse sees you, it's already in there, right? Mm-hmm. But even take that back. Imagine you're at home and you're thinking about going to an emergency room and you start putting that in. And the intelligence says, you know what? You don't need to go to an emergency room. You can go to the acute care center that's 3 miles away. Or your primary care doc is open and this is appropriate for that. These are technologies that we have today. We just haven't put them into play yet. And this is where our margin and infrastructure allows for us to be able to make those investments to do that. And this is where the government can also help us and payers can also help us.
Andy, I understand on transformational and payment systems, ACO is a big issue, I believe, in Maine.
For sure. Yeah, we have to Sonny's point, we've got to sort of re-envision care. We have to get increasingly comfortable providing more and more care outside the walls of our hospitals and physician practices. And when you really think about how the American healthcare system evolved, it really did after the experiences of military surgeons in World War I and World War II, to then bring those experiences back to treat individuals who had farm and factory injuries, which is really how our hospitals were created. That's what they were really especially created for. But yet most of us don't work in farms and factories anymore. We do more in rural communities, but still not exclusively. And what's really harming people these days are chronic diseases, and we don't really have a healthcare system designed to treat that. So we can't do that on our own. We're going to need payment reform that helps us create value for things that are really needed for our communities. Things like behavioral health, increasing primary care, the ability to really manage chronic diseases with non-physician providers. Those are things that we really need to get paid for and paid more for to really transform the way we deliver care, while at the same time ensuring that we can still perform the high acuity, highly specialized care that's necessary in emergencies in our hospitals. And there's some simple things that we can do in the meantime to kind of help us start to create a better environment. For example, for the most part, while there are some unique cultural differences between Maine, Vermont, and New Hampshire, the residents who live in these communities are still people. But yet we license our physicians, our advanced practice providers, our nurses differently in each state, even though we all operate facilities that are right on state borders.
Yeah, I wanted to ask about the licensing issue.
Yeah.
You all 3 states have different licenses. Why can't you get together, and standardize this across the board?
It's certainly a sensitive topic, but at the same time, given the proximity of the states, the closeness of the states, and the size of the combined population, it's something that I think is surmountable, something that we could figure out, which create a much greater deal of flexibility, not only in times like we're facing now, but if we ever have a future public health emergency, much like we experienced during the COVID pandemic.
There are parts of the country that have compacts.
Without question, and so I think there's a real opportunity for us to think that way in New England.
But this would require your 3 legislatures, state legislatures, to come together on.
It's more than the legislatures, it's the boards.
Boards of registration.
The boards of medicine, nursing, and you just have to align everybody's priorities and their benefits so they can all participate in it. We do share the same staff because when at the peak of traveling, I think some of my nurses that decided to travel went to Maine or went to Vermont, and some of their nurses came here. And it would make it far more sensible if we could actually have a 3-state shared awareness of our resources and use them as best we can. During the pandemic, they removed the distinction about licensure so people could actually provide services through telehealth, and if they had to actually go work in a contiguous state, that made that possible.
It actually helped us in northern New York, where we have 3 hospitals in northern New York, and it was critical that we can make that easier.
I realize this is hospitals and systems we're talking about, but even further downstream, I don't want to go to the hospital. I don't want health. I want to be, prevention is worth an ounce of whatever. What in the areas of social determinants of health, whether it's nutrition, whether it's education, whether it's, do your systems get involved in those kinds of issues too?
For sure.
Outside the
yeah,
hospital.
of course. And we're finding that the demand for those services is insatiable. And so that's where, again, we need some way, a great deal of that. Some of that gets funded through federal grants,
Right.
but there aren't enough grants to sustain that work in a meaningful way. And so whether it's things like food as medicine and creating food pantries for our community in a healthful way, or whether it's smoking prevention or smoking cessation programs, whether it's doing research in rural communities around chronic disease prevention, obesity prevention, we need to continue to figure out ways to fund that work to help us transform our business away from just getting paid to provide sick
Right,
care
right.
to really incentivizing us to do this so it doesn't feel as though it's work in addition to, particularly when we're feeling such financial pressures in the moment.
We have a Center for Advancing Rural Health Equity, which actually looks at the determinants of health across all the communities we serve. And there are a couple things that they've observed. Number one, 15 miles apart can be 15 years less on your life. And that has to do with not only a level of education, but access to care, as well as some of the choices that people make in their lives. And how do you actually come alongside a community and improve the health? No one organization, no matter how well funded or how well organized, can do it alone. So that means we've got to work with our communities. I would say some of our greatest partners are community leaders. I was at a town meeting with the head of the Mascoma Bank advertising for affordable housing. When we work together and stand up in community meetings and say, this will actually benefit the community, people listen. But we need to do it together. None of us can do it alone.
You started to go there, Bill, I'm sorry, with the ACOs and the idea, right? I mean, I think that really is a fundamental way that we have to change and think about the idea of capitation, the idea of sharing in the risk. And if the reality is our medical system works by rewards. If you reward something, it'll happen. If you penalize it, it'll take it away. So if you reward wellness, and the idea of these ACOs are that, we want to reward quality, we want to reward for keeping you out of the hospital,
Yes.
right? So when you start capitating and paying in a monthly per patient per month, and you're going to get that same amount regardless of what you do, whether you get it admitted or not, it changes the way that you deliver care. It changes the way that we get creative and innovative about, we're going to go to that person's home to keep them healthy, right? Because we're going to get rewarded to do that. Those are the payment reforms and the ideas that we need to push out, particularly in rural health, because people do want to stay home. They'd rather stay home if they can,
Yes,
right?
definitely.
And so whatever we can do at home and provide the services, the wraparound services to do that, I think our patients would be happier, and it would cost us less, and I think they would actually be healthier.
I don't want to miss the opportunity to talk about discharge, the lack of places to discharge to. How do we address that issue?
It's a big one. Since we've seen the financial challenges that have occurred in the aftermath of the pandemic, all of the things we've experienced have been experienced by communities, other private organizations, other not-for-profits in providing all of the care that happens outside of the hospital around us. So we've seen significant closures of skilled nursing facilities, rehab hospitals, ambulance services in a lot of communities have started to shut down. And so one of the things that all three of our systems have tried to do is step in and replace some of those important community services where necessary. And that's one of the advantages of having us as really being important partners in the community to try to step up in times of crisis like this to provide that. But we're going to have to really figure out a way to try to support these services, because without funding in the moment, with the workforce challenges that we're facing, and workforce challenges in terms of the numbers of participants as well as the housing and transportation challenges that are plaguing all of us, it's going to be a real struggle.
When you consider the fact that if we have a patient we believe is ready to be discharged, the payment for that patient stops. But if it takes another 10 days, 2 weeks, 3 weeks to find that patient a stable environment where they can recover a nursing home bed, a rehab bed, many of which were in short supply. We're continuing to deliver services to those patients without payment.
Okay.
And that actually really created tremendous stress on all of our organizations.
Quickly, there's a question here from somebody who's on the front line. Share with us how those of us who work on the front lines and live in rural healthcare region can make a difference or solve these challenges. What can we do to help? I thought that very nice that somebody out there recognizes you have these challenges. What can they do?
Well, I'll start with just keep working. It's great. I mean, the work, we have to keep reminding our employees that the work that they do is really mission driven, regardless of what they do. I said that before, and I really think that's important. But all of the folks that are out there are also our recruiters. And so you talked about, we're bringing high school students in, but they can encourage that in their communities, to look at this as their future work. Right?
Mm-hmm.
Come check out what this hospital is like. Come to work with me. Encourage people, their students, their kids, their cousins, their neighbors, to go into this line of business. We all have open jobs that we're looking for people, so they can all help us on the front line by being fellow recruiters with us.
Yeah. They can also help us innovate. We know we have to replace vacancies with technology, but there are probably ways on the front line that they can see that they may be able to do their job differently, that would be more efficient. They're the ones that actually have the answers.
Yes, yes.
And we need to unleash them to share them
Yep.
with us.
Yeah, at the end of the day, just continuing to provide remarkable care for our communities and delivering empathy at every moment.
We are coming to the end of this very good conversation. I want to know if there's, before I have a couple of closing comments, what any final words you would like to share with the audience out there about your systems and the care that you do provide.
I think just our commitment to our communities and our desire to be there long term for them, to continue to build those trusting relationships with our patients and ultimately impact the health outcomes of the communities we serve.
I would say that having people understand that we have unique insight in terms of the challenges of delivering care in rural America. And although New England is not always perceived as being very rural, between the three of us, we have rural northern New England, and we can help people actually figure out where the resources should be put so we can actually continue to survive.
Yeah, the one thing I think we haven't hit on, but I think all of us believe in, is that our legislators, right, local, state, federal, they can have a huge impact here. And I think we know what we need to do. We know where we need the money and the help and resources and change. And I wish they would come with us a little bit more than they do today. It'll make a huge difference.
As we wrap up this program, I want to thank each of you for sharing your insights with us today. It's the start of a critically important conversation here in New England and across the country, quite frankly. A few weeks ago, I was driving home from my office in D.C. to Northern Virginia, and I heard an interview on Marketplace, Kyle Risdahl, with one of your physicians, Joanne, here at Dartmouth Health, Dr. Eric Henderson, an orthopedic oncologist. He discussed a lot of the same issues that we have discussed here today about the challenges facing rural medical centers, but he ended by speaking of the beauty of the White Mountains, the Green Mountains, the ability to walk out and see God's nature out there. I guess they advertise priceless. So let's not forget, there is much to be said about rural life and rural the development of hospitals and systems to serve these people out here who enjoy this area of the country. So thank you again. Thank you to the public and the media for your interest and the questions that we received today. There will be more on this topic to share with you all in the future. Thank you for turning in, and have a good day.